Welcome to this renal cell carcinoma tumor board sponsored by Pfizer and the NCCN through Duke University. My name is Tian Zhang. I'm one of the GU medical oncologists.
My name is Lisa Ho. I'm a radiologist.
My name is Wenqi Fu, and I'm a pathologist.
I'm Mike Harrison. I am a GU medical oncologist.
And I'm Brant Inman. I'm a urologic oncologist.
We'll start off with our first case today. This is a 61-year-old man who was seen in consultation for a suspected renal cell carcinoma. He developed progressive weight loss of 40 pounds over a year, as well as loss of appetite and weakness. He had been worked up prior to this for weight loss, which was presumed to be due to gastroesophageal reflux disease. He then presented with gross hematuria and clots in his urine. On exam, his vital signs were normal. His Karnofsky performance status score was 80. He was a well-appearing man and otherwise in no acute distress. And otherwise, he had a normal physical exam. His comprehensive metabolic panel was significant for a normal creatinine of 1.2, a calcium of 9.3, but albumin of 2.4, so corrected calcium level was high at 10.6. His complete blood count showed anemia with hemoglobin of 9.3 and hematocrit of 30. His white blood cell count was 11.9 with neutrophils of 7.7, and his platelet count was 377,000. He underwent a CT abdomen.
This is a coronal reformatted CT of the abdomen with contrast, showing a large mass originating from the upper pole of his left kidney. You can see that there's some central necrosis. This next image is showing that there was invasion or tumor within the left renal vein, and the arrow is pointing to that area. Next image. This is an image through the lung bases showing that he had bilateral pulmonary nodules, which were indicative of metastatic disease.
So our case one discussion points include the necessity of biopsy and the role of cytoreductive nephrectomy. So for that, we'll turn to Dr. Inman.
So the need for renal biopsy is determined by what your next step might be. So if this patient is considered a candidate for cytoreductive nephrectomy and his performance status is reasonable, then there's really no need to do a biopsy because you'll have a really large biopsy with your nephrectomy. On the other hand, for patients who are not candidates for upfront cytoreductive nephrectomy, either because their performance status is poor, they have a contraindication to surgery such as anticoagulation, or they just refuse treatment, then a biopsy should be done prior to initiation of any systemic therapy to ensure that you have a good histologic diagnosis. The one thing about this particular patient that concerns me is the presence of thrombus within the left renal vein. Generally speaking, we have two reasons for doing cytoreductive nephrectomy. One is for symptoms, and two is for a potential survival benefit. There might be a third reason, and that's to prevent sudden death. And in the case of patients who have venous invasion by tumor, whether it's in the renal vein or within the vena cava, we often consider cytoreductive nephrectomy in that setting, even if it's a patient who doesn't generally meet excellent criteria for surgery, because we're worried about sudden death from massive pulmonary embolization. So in this particular patient, an additional concern for me is the risk of sudden death from a pulmonary embolism. And if he doesn't undergo cytoreductive nephrectomy, he should be anticoagulated to prevent progression of this thrombus.
Great. What other staging studies would we need at this point? Dr. Harrison, would you comment?
Well, certainly, anytime we're thinking about systemic therapy and we're thinking about local therapies, we want to know the full extent of disease. In a patient like this with a large renal tumor with spread to the lungs, an MRI brain may be reasonable, as we may be thinking about VEGF inhibitor therapies. Certainly a bone scan is probably reasonable as well as baseline staging studies.
Maybe, Mike, we can comment on the MRI of the brain for a second. When do you consider, what are the general criteria that you consider for obtaining imaging of the brain? Do you do this in every patient with metastatic disease, in selected patients? Are there certain factors you're looking for?
No, that's a good question, and I think it's also a question of timing. So certainly if the patient has a normal neurologic exam, the patient has a pretty good or intermediate risk, and we're thinking of taking them to cytoreductive nephrectomy, it's not necessarily going to change what we do in the short term to do an MRI of the brain. So we might take them to cytoreductive nephrectomy, and then we might do the MRI of the brain afterwards. Where the MRI of the brain can change what we do is when we're thinking about systemic therapy. So as I mentioned before, the data as far as VEGF inhibitors such as sunitinib, pazopanib, even bevacizumab is really in the setting of patients who either did not have any brain mets and they were imaged with an MRI of the brain or at least a CT, or patients who had treated brain metastasis. So in patients who are thinking of starting on VEGF inhibitor therapy, we want to get that as a kind of a safety measure. The second reason we might want to get an MRI of the brain is we maybe would find several lesions that were asymptomatic, that were small, that we could treat in a different way, for example with stereotactic radiosurgery, rather than treating them with whole brain radiotherapy, which has a lot more morbidity and may not, frankly, work as well in renal cell carcinoma. So that's kind of my way of thinking about it. And so ultimately it would kind of depend on what this patient's next therapy is going to be when we did those studies.
Great, thank you. This patient had another CT chest, abdomen, pelvis 3 months later, and this was their scan.
And this is a coronal enhanced CT through the abdomen, again showing the tumor in the left upper pole of the kidney. The arrows are pointing to the central necrosis within the tumor, and also again to the filling defect in the left renal vein, which is concerning for either lead or tumor thrombus.
Great, thank you. For discussion about prognosis, Dr. Harrison, would you comment on his prognostic risk factors?
Sure. This patient would be predicted to have an intermediate risk by either the HANG or the MSKCC criteria with 2 risk factors. And if I remember back, I believe it was an elevated calcium and a low hemoglobin. What I think is not captured in that is if you look at his KPS, it's technically not at the cutoff that would give him a 3rd risk factor. So it's 80, it would need to be 70. However, it's right at that borderline. He also has significant constitutional symptoms. So he's had a significant weight loss. He has almost kind of an inflammatory picture going on. And these are patients you really worry about. So if you're thinking about cytoreductive nephrectomy, potentially that's going to delay the patient's systemic therapy for quite a bit, and maybe Dr. Inman could comment how long. But in this patient, I would specifically be concerned about delaying his systemic therapy.
Yeah, the question of how long to delay a systemic therapy after surgery is a really good one, and it depends on how we do the surgery. For smaller kidney tumors where we can perform the surgery laparoscopically, the patient typically would leave the hospital on day 2 or 3 after surgery and would be probably fine to receive a systemic therapeutic agent within about a month. On the other hand, a case like this where there's a large renal mass and where there's at least a renal vein tumor thrombus, this is going to be an open surgery almost certainly, and the postoperative recovery is probably 4 to 7 days in hospital depending on how good the patient is going in, and the recovery period is much longer, and we're probably looking at 2, maybe even sometimes 3 months before they end up on systemic therapy. So you're right, I think for a larger tumor we're certainly going to delay the time to systemic therapy. The one question is, though, as we don't know if the systemic constitutional symptoms are coming from the kidney or the metastases. And in that case, sometimes when we do a cytoreductive nephrectomy, we do get rid of some of the constitutional symptoms. I think it's really difficult to predict which, and often we end up doing a nephrectomy in a patient like this, and they actually don't get better from a constitutional symptom standpoint. So I'm not sure in this particular patient which treatment would make more sense. I think you'd have to base it on how the patient feels about it and what your overall feeling. I agree with you, though, the weight loss is highly concerning and for me would put this patient in a higher risk level than we think from the traditional criteria.
Great. So that was an excellent discussion about his risk factors and choices. And at this point, would you comment about the choice of first-line systemic therapies for this patient?
Sure. So generally, the choice of first-line systemic therapy is either a VEGF inhibitor, so such as sunitinib or pazopanib in good or intermediate risk patients, or maybe something like temsirolimus in either poor risk patients or patients with alternative histologies such as maybe papillary, so in other words, non-clear cell histologies. So again, I think what's important in this patient is the significant fatigue and weight loss. When you think about first-line systemic therapies like pazopanib and sunitinib, those are typically causing fatigue in the majority of patients. If you talk to this patient and the patient was motivated to maybe turn the symptoms around, maybe try to go to a nephrectomy if he was otherwise appropriate, I might lean against drugs like pazopanib or sunitinib for that reason, because he might actually be pushed over the edge and his performance status might actually worsen. On the other hand, what favors a drug like temsirolimus is he's really nearly poor risk. If you wait another month, he's going to be poor risk on the basis of 3 risk factors. He has a little bit of this kind of inflammatory syndrome. Anecdotally, that kind of tends to respond to a drug like temsirolimus. We didn't have an LDH. Interestingly, LDH possibly might predict a response to temsirolimus. I would suspect that might be high in this patient. So overall, depending on what the patient's goals of care were and so on and so forth, I might actually lean towards a drug like temsirolimus in an attempt to stabilize some of his constitutional symptoms, let him potentially gain weight, feel a little bit better, have a good quality of life, and see how things go over the next several months.
Great. So the patient started systemic therapy with temsirolimus, 25 milligrams IV weekly. And 4 months later, he underwent a bone scan.
And this bone scan basically shows that he had no sites of metastatic disease in his bones.
And now we have a comparison of his CT chest from the initial to 7 months later after temsirolimus therapy.
And you can see on the image on the right, which is the follow-up, shows that the lung nodules have markedly decreased in size compared to the initial scan.
So now, after he's responded to temsirolimus as first-line systemic therapy, we should go back and talk about the role for cytoreductive nephrectomy at this point, once the patient stabilized.
Yes, so in patients who are considered not great surgical candidates at the outset, but that do have an excellent response to systemic therapy, in this case an mTOR inhibitor, but also potentially with a tyrosine kinase inhibitor, and this guy in his lungs has a near complete response from what I can tell, we would typically give the patient the benefit of the doubt. And generally, like Mike mentioned previously, their performance status might actually improve on therapy. And if his performance status improved and he was a good candidate for surgery, this would be a good patient to consider for cytoreductive nephrectomy. The caveats I mentioned previously still apply. We'd have to assume that there's thrombus in his renal vein. I personally think that that's best managed with an open surgical approach rather than a laparoscopic approach because of the risk of intraoperative embolization. And so I think an open cytoreductive nephrectomy would be very reasonable in this patient, and I would strongly consider it.
Great. So the patient did undergo a left radical nephrectomy, a distal pancreatectomy, and a splenectomy at this point in his disease course, and Dr. Fu will comment on his pathology.
Sure. So the slide shown here is a representative section of the tumor that was in his kidney. So a fair amount of it had become necrotic, but what's shown here is sort of residual viable tumor. On the right side of the slide, you can see a more well-differentiated area of the tumor that has a fairly classic morphology with cells with abundant clear cytoplasm, round nuclei, and relatively prominent nucleoli, and that would be really good morphology for a clear cell renal cell carcinoma. On the sort of left upper hand side of the slide, you can see that some of the cells are getting a little pinker, or a little bit more eosinophilic, and that's sort of going along with a higher grade of the tumor. The next slide shows a more poorly differentiated area of the tumor, and you can still see some areas that have clear cell morphology, but you're starting to appreciate a lot more pleomorphism or variation in size and shape of the nuclei. Some nuclei are 10 times the size of the nuclei next door, and the nuclei are again very prominent. So this was consistent with a Furman grade 4 clear cell renal cell carcinoma. So this nephrectomy that was done was also done with a resection of the pancreas and the spleen, and this was not adrenal sparing, so the adrenal came along with it. The tumor had actually extended outside of the kidney into perinephric fat, and it did not quite invade the adrenal or the pancreas, but it came within a millimeter. So the image shown here shows representative tumor at the bottom of the screen, and then in the upper left-hand side is adrenal. And you can see that it has come very close, but it has not quite involved it.
Dr. Fu, you commented on the poorly differentiated nature of this renal cell carcinoma.
Mm-hmm.
Can you just touch on the sarcomatoid features and whether this pathology had any sarcomatoid features?
Sure. So this particular one did not have either sarcomatoid or rhabdoid features. So sarcomatoid or rhabdoid features would give a clear cell renal cell carcinoma sort of automatically a Furman grade 4, which is the highest grade that there can be. But you can also get to Furman grade 4 nuclei with just sort of frank bizarre atypia, which is what this particular tumor had.
Thank you.
Mm-hmm.
So now we'll talk about where the patient should go after surgery. Should he resume temsirolimus, and if so, what's the timing for resuming systemic therapies?
So I think, this is something that typically we would discuss very carefully with the surgeons, make sure that the patient is adequately healing. These drugs, and I'm including VEGF inhibitors and mTOR inhibitors like temsirolimus, can cause wound dehiscence and at least wound healing difficulties. So we really want to make sure the patient is healing the wound well. In this particular patient, because the patient had a pretty good response in the lung, there's probably no urgency to start the temsirolimus after therapy. And I think you could probably fairly argue, as was mentioned, if he does have a complete response, maybe you don't need to start the temsirolimus at all until the patient develops progression. I think the caveat to that is that we do not believe that drugs like temsirolimus cure patients, so they do not typically induce durable, complete responses after you discontinue therapy. So in this case, I would probably just resume the therapy, but I would be okay with waiting a little while to make sure he adequately healed.
Yeah, I agree with that, and I would say that this case also demonstrates the point that when we're doing cytoreductive nephrectomies and we're aiming, batting for a home run, looking for a cure, sometimes it requires resection of multiple organs. It could be colon, in this case it was spleen and tail of pancreas. And these are things that if you're attempting cytoreductive nephrectomies on large tumors, you got to be ready to do. For us, surgically, we don't know if it's microscopically invasive into adjacent organs, and so we try and remove them en bloc so that we don't leave positive margins or cancer behind, for which we might have a local recurrence and more symptoms. In a patient who's had a distal pancreatectomy, this is certainly a patient that I would wait a little bit longer than average for healing, because a pancreatic leak, should that develop, would be a pretty significant complication. So I would probably agree with you, Mike. I'd want to image him before starting therapy and make sure that there's no evidence of pancreatic leak and everything is healed internally.
Great, thank you. And if the patient progresses on temsirolimus after restarting, what would your next systemic therapy option be, Dr. Harrison?
So that's a good question, and the short answer is we don't really know what the optimal therapy in that setting. In other words, progressing on an mTOR inhibitor in the first line, what that next optimal therapy is. If you look at the Global ARC trial, which was what led to the approval of temsirolimus, most of those patients did not survive long enough, unfortunately, to get second-line systemic therapies. There is some evidence in the AXIS trial, which was the randomized phase 3 trial of axitinib, that there may be activity of axitinib after temsirolimus, so that is what I might use. Certainly, there would be other potential options as well.
Thank you, and that concludes this case. Our second case today features a 44-year-old man who presented with 18 months of fatigue, arthralgias, night sweats, and weight loss. He had extensive infectious disease and rheumatologic workups, which were all negative, including 2 courses of treatment for tick-borne illnesses. An abdominal ultrasound was performed for fever of unknown origin, which demonstrated a right renal mass measuring 10 by 8 by 10 centimeters. He underwent a CT of the abdomen and pelvis, which confirmed a 10 by 9 centimeter right upper pole renal mass with partial duplication of the collecting system, no lymphadenopathy, and a CT chest was negative for metastatic disease. He had an initial surgery with a right laparoscopic nephrectomy and regional lymph node dissection. Dr. Fu, can you describe his pathology?
Sure. So he had a very high-grade clear cell renal cell carcinoma with 2% sarcomatoid features. So when we say that there are sarcomatoid features in a carcinoma, that typically means we're seeing morphology that is very atypical, high-grade in appearance, often spindled in appearance, and that is generally associated with a poorer prognosis. And so even if it's very focal, we would still report a Furman grade 4.
Great, thank you. 1 year later, he was undergoing staging CT when he had a chest, abdomen, and pelvis CT performed. This showed in the medial edge of the right middle lobe of the lung, he had a nodule that was previously measuring 0.8 by 0.9 centimeters 3 months prior, and that had increased in size to 1.3 by 1.4 centimeters. There were no other definite evidence of metastases. So for this patient, we were hoping to discuss additional staging as well as role for biopsies or metastacectomies at this point.
I'd like to make a comment first about the history. The first question that pops up, I think, for many patients is, at the time of his first surgery, when he had stage 2 high-grade sarcomatoid renal cell carcinoma, was there a role at that point for adjuvant therapy? Should he have received systemic therapy after nephrectomy? And this is a common question that patients ask when I tell them they're at a little bit increased risk of recurrence because of the sarcomatoid features in their tumor. They ask if there's anything that we can give to prevent that. And I was wondering, Mike, if you could comment on that. What do you think?
Sure. No, this is a great question, and this, again, is a question that's commonly asked by patients. Given the activity of drugs like Sutent, sorafenib, et cetera, in the metastatic setting, it could be reasonably wondered maybe we should try to treat high-risk patients to try to reduce the risk of recurrence or at least delay recurrence. So as far as the evidence that is known right now, recently the ASSURE study, which was looking at adjuvant sunitinib or sorafenib, did not show a benefit to adjuvant treatment for high-risk patients with localized renal cell carcinoma. There are multiple other studies, STRAC, Everest, using other agents, including axitinib, everolimus, etc., that have accrued and are waiting to read out. But at least the first results that we have do not support adjuvant therapy at this point, unfortunately, for patients.
Yeah, I think that's exactly what I would tell the patient too. And the other thing is, patients with sarcomatoid tumors in general are not generally very responsive to tyrosine kinase inhibition or mTOR inhibitors that we know of.
Right.
So, there's maybe those two reasons. As for this patient's lung lesion, it's small, it's unifocal. For me, this at this size, 1.4 centimeters, it might be very difficult to biopsy. Generally, lesions at 1 centimeter in size can be tricky, but I would consider this potentially for a resection. This is a tumor on the imaging that is very peripheral in the lung, and would look to me to be amenable to thoracoscopic wedge resection. So my first thought would be, well, it's a unifocal site of disease. Maybe it can be resected, but before doing that, I'd want to make sure that there was no other disease elsewhere. And for me, that would include a bone scan. To look for disease in the bone, and if he hadn't had a CT of the abdomen and pelvis, but I think he did, I would check that. But if the CT of the abdomen and pelvis was fine, the bone scan was clear, and with a solitary lung lesion, I personally wouldn't scan the brain. I would generally do that when the burden of disease above the diaphragm is high. So multiple or lung metastases is when I would, or multiple lung and bone metastases, that's when I would consider checking his head.
Yeah, no, I agree. And I think certainly in this patient, a metacystectomy would make sense. I think the thing to realize with systemic therapy is that it has real side effects. The progression-free survival, depending on what drug you use, sunitinib, pazopanib might be appropriate in this patient, would be about 8 to 9 months. But during that time, the patient is having side effects, fatigue, hypertension, et cetera, et cetera. Whereas if you could treat the patient with local therapy, potentially do a wedge resection or some other way pluck out this nodule, even if all you did is delay the time to systemic therapy, that would be a benefit to the patient.
Yeah, and for thoracoscopic wedge resections, the recovery period is remarkably quick. Patients leave the hospital usually within a couple of days, and usually within six weeks are pretty much back to baseline, assuming that there's no complications.
So the patient did undergo a right thoracoscopic wedge resection, and the pathology showed a 1.3 by 1.2 by 1 centimeter clear cell carcinoma with negative margins. Dr. Fu, do you want to comment on his immunohistochemistry staining?
Sure. So the immunohistochemical findings on the lung nodule showed positive staining for RCC and CD10, as well as some patchy staining for vimentin and anti-cytokeratins, and those are all very consistent with a diagnosis of metastatic clear cell renal cell carcinoma. A TTF1 immunostain was negative, and that was done to make sure that it wasn't a pulmonary adenocarcinoma, and those tend to be positive for TTF1, whereas a renal cell carcinoma would be negative, as this case was.
I think this case demonstrates really the role of metastacectomy in renal cell carcinoma. It also demonstrates the patients that tend to benefit. So metastacectomies tend to work best in people who have lung-only disease versus disease in other sites, although it can be beneficial in those other sites. It tends to benefit patients who have asynchronous recurrence of disease rather than synchronous disease. And it tends to benefit patients who have a low number of metastases, 1 or 2 versus 3 or more. So this patient basically had several risk factors that would suggest a good outcome with metastacectomy. Solitary, lung-only disease.
Thanks very much for that commentary. And the patient has remained without evidence of disease now 4 years after metastacectomy, so he met all those criteria. That concludes this case. Thank you for joining us for this session of the Renal Cell Carcinoma Tumor Board.